Hi, and welcome to the September 2015 Plastic and Reconstructive Surgery Journal Club. This is Dr. Apresh Singla, and my name's Damien Marucci. So as usual, we did 4 papers this evening. So the first paper, Apresh, was Embrace the Change, Incorporating Single-Stage Implant-Based Breast Reconstruction into your practice, and this was out of Atlanta, Georgia. So Apresh, in a nutshell, what was this paper talking about?
So the paper, the reason for writing the paper was because of a resistance by surgeons to incorporate single-stage breast implant reconstruction into their practice, and it essentially was experience of a single senior surgeon describing that nipple-sparing mastectomy followed by a single-stage breast implant reconstruction is a safe and a viable option in a highly selected group of patients, and that surgeon experience plays an important role in the success of this procedure.
Yes. They go through the various types of incisions that can be used in order to perform the nipple-sparing mastectomy. The key features of the surgical technique was a subpectoral pocket with acellular dermal matrix, and it was a tight pocket technique using a sizer to accurately ascertain the size of the implant. There was some conflicting evidence, or there was some conflicting reports in the paper. In the text of the paper, they said the ideal candidate of the paper is a patient who wished to be either the same size or slightly larger. But then when they spoke about patient factors in one of their figures, they actually said should be either the same size or slightly smaller. But certainly the case reports were either the same size or slightly larger, I think that the impression was. Overall, their complication rate was very low. For patients who did have infected seromas, they were able to salvage things using a washout technique after Sforza, which was a paper which we discussed last month in Journal Club, and replacing with a smaller, smooth, adjustable implant. So basically taking them from a one-stage technique to a two-stage technique again. What did people think of the paper?
So I think the general consensus was it was a good paper, and it just illustrates that single-stage implant is a really viable alternative to more complex flap surgery, and we should think about now incorporating this, and certainly there's a trend in the States that this will now eventually probably become mainstream in the near future.
Okay. All right. Okay, the second paper was also from PRS in 2015. This was the superficial inferior epigastric artery versus the deep inferior epigastric artery perforator flaps, looking at arterial complications. This was out of Ontario in Canada, where a single surgeon was the sole reconstructive microsurgeon for a population of 2.3 million people, and this one surgeon was doing all of the microsurgical breast reconstruction. So what was this paper talking about, Apresh?
So the main reasons behind the paper was that there was still some equipoise regarding the reliability of the SIEA flap with regards to the DIEP flap, and essentially what this paper has clearly demonstrated is that the SIEA flap, when compared to the DIEP flaps, has a significantly higher arterial complication rate, which includes thrombosis and necrosis, necrosis requiring debridement, and this explains the high rate of re-exploration and flap failures with SIEA flaps, and these flaps should really only be done in institutions that have the necessary experience and a demonstrated success rate with using this flap method.
I guess one of the issues that came up with this paper, it was a single surgeon experience. The surgeon did not do any preoperative imaging, whereas certainly the vast majority of reconstructive microsurgeons performing breast reconstruction do angio-CT scans in order to assess the vascular anatomy of what's going on. Certainly the experience presented was very unfavourable with respect to their experience with SIEA flaps, and of the 6 flaps that experienced arterial insufficiency, none of them was salvageable. So I guess one of the things that people spoke about was in a multi-centre, multi-surgeon study where perhaps preoperative imaging was performed, and so more surgical planning could be performed, whether the results could be different, and whether there may be a niche for SIEA flaps in other centres with the set selection criteria based on the imaging. Okay, so on to paper number 3, which was Oxygen Reduces Tourniquet-Associated Pain, a double-blind randomised controlled trial for the application in hand surgery. This was also published in PRX. It was out of Oxford in England. And how would you summarise this study in a nutshell?
The main goal of the study was to look at whether giving oxygen during the use of a tourniquet for upper limbs surgery potentially reduces the pain and allows for longer time till the patient reached a clinical pain threshold, which was defined as 40 on the visual analog scale. And what it showed is that supplemental oxygen appears to reduce the overall pain by almost 1/3 and extends the time taken to reach a clinically acceptable pain threshold defined as 40 on the VAS scale by more than 6 minutes. So essentially they recommend with the use of oxygen supplementation, which is a cheap and readily available intervention that can help improve the tourniquet use.
And this is a very nice double-blind randomised controlled trial with healthy volunteers, with the caveats. Obviously these are volunteers with uninjured upper limbs, and so they didn't have any confounding factors of pain in the hand that obviously which may be applicable to patients who are undergoing hand surgery, in particular in the emergency setting. We discussed afterwards that certainly here in Sydney, the vast majority of patients undergoing hand surgery, whether elective or emergency, tend to have a general anaesthetic. It'd be interesting to see whether with increased rationalisation of resources, whether there is a push towards more procedures being performed without general anaesthesia, perhaps with sedation or even no anaesthetic. Certainly in the United Kingdom with the NHS, many more surgical procedures than in Australia are performed without any anaesthesia at all, and so this is a particularly relevant study for them. All right, the last paper we did, algorithm for the management of intracranial hypertension in children with syndromic craniosynostosis. So this is a very specialised paper, but as we discussed, there is a very overwhelming preponderance of paediatric plastic surgeons amongst clinical examiners, so it's something that you need to know something about. Syndromic craniosynostosis is the premature fusion of the calvarial sutures. It can lead to problems with raised intracranial pressure and associated developmental delay and visual disturbances. This study was out of the Netherlands for the sole craniofacial unit which services that country. What they looked at were all syndromic and complex craniosynostosis patients referred to the Dutch Craniofacial Centre over a 5-year period, comprising 62 patients, and they looked at the management of intracranial hypertension. The 3 main things they were looking at was occipitofrontal head circumference and how that changed with time, the presence or absence of obstructive sleep apnea, and also the presence or absence of papilledema or optical coherence tomography, or finally intracranial pressure monitoring. And so what did they find?
Okay, so the main finding of the studies was that, that children with syndromic craniosynostosis are at risk of intracranial hypertension, and that impaired head growth is a major determinant, especially after bolt expansion surgery at varying ages, of determining those children that may have intracranial hypertension. And the presence of moderate to severe obstructive sleep apnea, although wasn't associated at 1 year post-op bolt surgery, in the longer term is also increases the risk of intracranial hypertension in those kids with syndromic craniosynostosis.
Yeah. So I thought this was a very important paper. Obviously the numbers are small, but that's just a factor of the nature of the rarity of these conditions. But it is something that certainly we'll be looking at in the unit I work at, I've got to admit we haven't put a lot of faith in head circumference measurements because it seems to be particularly inexact, whereas this group were able to show that a tapering of those head circumference measurements, in particularly more than 1 year after vault expansion surgery, can be a harbinger of raised intracranial pressure. All right, well, I guess that's about it. For those of you who were there, I hope you enjoyed it, and for the rest of you, thank you for watching. Okay, bye.
Sitting in this hotel room, my past seems here to stay. Life has taken turns that always bring my pain to play. Take me